Now we are going to have Brenda Sequeira de Melo. Brenda is an obstetrician, gynecologist, and a technical advisor in the Maternal Newborn Health Program at CCBRT, Tanzania. Welcome, Brenda.
Thank you, Rose. May I have my presentation, please? Okay, so while I'm talking, again, I work for CCBRT, a Tanzanian NGO that is dealing with disability. And over the last 2 years, it has expanded the program to include a program of prevention of disabilities. And by disability, we are referring to fistula and cerebral palsy. And that was how the Maternal and Newborn Health Program at CCBRT initiated. So I'm just waiting for a few minutes until my slide comes up, because... So as we wait for the slide, I will try and do what the MC of the initial and tell you some stories. So I'm going to tell you the story of a girl that you will see a picture come up very shortly, and her name is Beatrice. Beatrice is a survivor. She's one of the 4 million residents in the city of Dar es Salaam, and a couple of years ago, she was one of the 70,000 pregnant women that delivered in one of the 3 municipal hospitals in the city of Dar es Salaam. Beatrice did everything right. She booked early. She even was accompanied by a very, very cooperative husband. And when labor pains started, she presented herself to the hospital on time. Dar es Salaam is a unique city. In controversy to the rest of Tanzania, it has a 98% facility delivery rate, and most people choose to deliver in a facility. So here we see Beatrice. This was about 3 years ago. Next slide, please. So this is the award that Beatrice presented to. She did not have a bed to herself. And in a ward like this, once you get admitted, you get examined once. And then you wait in silence, and you labor in a kind of a silent bravery. The one who screams and shouts and you start pushing, or you hemorrhage, or you fit, then 5 women will give way and you will get the bed. There's a very surreal understanding there. Beatrice was examined by the doctor, and she was told that she was not in labor and needed to go home. So she told the doctor that she felt so much pain, she felt like the baby was coming. And she was asked, "Did you go to medical school? Are you a doctor now?" And so Beatrice went home. So in this ward, we can see very evidently that none of the pillars of respect for maternal care are evident. There are no privacy, there's no kind communication, there's no consent, there's no information. Anyway, Beatrice went home, and she labored there for 3 days. The pain got severe, but she was too afraid to come back because she did not want to be shouted at. A couple of days later, in a very poor condition, Beatrice was taken back to the same hospital. The horrific story continues because Beatrice lost the baby, and as the baby had been stuck at the outlet for an extreme amount of time, the tissues around the vagina had deteriorated and a hole developed between the birth canal and the bladder, and she started leaking urine. She thought that if she stopped eating and drinking, the leaking would stop. And so a couple of days later, extremely malnourished and dehydrated, a neighbor who had heard the awareness-raising messages on radio brought Beatrice to CCBRT, where she received treatment, rehabilitation, and is now completely cured. Beatrice told this story in front of a group of doctors and nurses. It is a custom, and at that time there was not a single dry eye. It is customary in CCBRT, when we train doctors and nurses, to engage the survivors in the advocacy for change. So one of the things that we do in the trainings is that we allow a moment when we ask guest providers, and we just actually make a group apology for what has happened, and we allow a moment of reconciliation. And I find that is very powerful because it's uncomfortable to hear the story, and I feel that that discomfort you feel as a provider may be the beginning of change from within. What is also deeply concerning is that Beatrice, after the testimony, confided in me that she was 6 months pregnant and she hadn't booked. She was afraid to go back to the facility. She needed extensive counseling and cajoling, and she needed me not as a OBGYN. She needed me as a birth supporter. She needed me to be the protector of her dignity and her safety. The story of Beatrice is one of 502. Last year, CCBRT operated 502 cases of fistula and hundreds of cases in the years before. Every case, every patient with a fistula is a testimony of the most severe form of disrespectful maternal care. And not only disrespect, there's neglect, there's abuse, there's near dying, there's disability, there's loss of dignity, there's social exclusion, there's self-stigma. Not only is the situation dehumanizing, it is also dangerous. I would like to take you back to the ward. This is the postnatal ward in the same hospital that Beatrice delivered. We have 3 hospitals that look exactly like this, that on average deliver 22,000 to 29,000 deliveries annually. That breaks down to about 80 deliveries a day. That breaks down to every 20 minutes a head emerges. The midwives react to an emerging head. Normally, midwives, the minimum amount of time you need to spend on a patient is 1 to 2 hours. So if you do the maths, you can calculate what this kind of ward needs, the staffing that this ward needs. But I will tell you that the maximum that this ward has is 4 nurses on the morning shift and even less at night. Now imagine 1 nurse helps the doctor in cesarean section, 1 goes in the ambulance to escort the patient to the upper level center. 1 is busy filling the number of reports that are demanded by the numerous vertical programs. Imagine being left alone in a ward like this. If you have a hemorrhage, you need a minimum of 4 people. You call for help, who will come? You might get the askari. That's the watchman if you're lucky. If you look at this picture, I can see panic, I can see frustration, I can see desperation to get the baby out. I can see a facility that there is no privacy. I can see that a lack of supplies. When we started in 2010, there were not enough supplies. The infrastructure was deteriorated. To use the washroom, you had to leave the block. There are no tea rooms for the nurses. So and the access to backup is very late. So it lends itself to a sense of panic. It oozes with a violation of all the elements of respectful care that we heard mentioned early, and breeds danger and disrespect. So what I would also like to say, I'd like to ask you, what do you feel when you see a picture like this? This extreme overcrowding, congestion. I would also like to tell you that one of the words that comes to my mind is overwhelming. When I work in a ward like this, I am constantly humbled by the bravery and tenacity of the health providers that work here, very, very long hours with very low pay. I salute Rose. She's a nurse midwife that over 3 months delivered 695 live births. We wanted to recognize her, and we bought her a nurse's watch so that she could measure the pulse rate. It cost us $2 on eBay, and we gave her a lunch voucher for lunch for her and her extended family, and she cried. It was the first time in 15 years that she had been recognized. So my point is that I do not condone or excuse or justify abusive behavior. I agree that there is no tolerance, there should be zero tolerance for abusive behavior. But when I look at this, I ask myself, what can I do? What can I do to add the element of respect? What can I do to make pregnancy less dangerous? Can we really separate the elements of respectful care from the elements of critical care? Are we really too poor to cover, to communicate, to show compassion and to care? I don't have an answer, and unfortunately in maternal care there is no powerful vaccine. It demands many players and multiple systems and multiple parties all working together. But what I know is that I'm committed to trying. I'm committed to trying to do whatever I can do to change this picture and add the component of dignity and safety to the whole situation of childbirth. And I'm very fortunate that I work in an organization that is allowing me to fulfill this purpose. 3 years ago, CCBRT expanded the fistula program and encompassed a maternal and newborn health capacity building program. And we're partnering with the region of DAR and working with funding from the European Union and CBM. The aim is to decongest the municipal hospitals. What you saw in the story of Beatrice, it was a decongestion by discharge. We need critical space so people are discharged just to make space. But what we try to do in the region of Dar is build capacity in health centers and dispensaries so that the normal cases can be downshifted, while simultaneously a maternity hospital is being built that in 2 years' time will be able to absorb some of the more high-risk cases. And we're also engaged in a capacity building program across these 16 sites. What we do is nothing original, nothing invented by us. We've picked from the wealth of literature that is available, and we are implementing the evidence-based best practices that are recommended by the Ministry of Health. We invest heavily in training, infrastructure, community mobilization, and health systems strengthening. What we do is, because we work very closely, everything is planned, implemented with the local governments. So they tell us how we should do it, and that lends itself into, it fits the intervention to the context. So one of the things that we have done, this is a picture of the same ward you saw in the beginning, because I really believe that all the training in the world cannot ensure privacy. If you want privacy, you need to invest in curtains. If you need the patient to get a bed and you give them a BP machine, you still will not have one patient, one bed. That really is my dream for this ward. We were very lucky that a private donor, as part of corporate social responsibility, has invested 100 million Tanzanian shillings and renovated an old kitchen block. And so we've got 32 additional bed spaces. So can you see the picture changing? And we're moving more nearer to the vision of one bed, one woman, privacy. We even added space for kangaroo mother care. One of the things we have done is implemented standards. And what I like about the standards is that they describe specifically what the provider must do and what the managers must do. And they include in them elements of respectful care. They include greeting, privacy, sensitive vaginal exam, covering, communication. We are measuring these standards over time, and we're very encouraged. The progress is slow, but it's there. So we look over time, the blue is the baseline. Then after 6 months, we went to a red. And then we invested more in coaching, mentoring, brought us the doctors, empowered quality improvement teams, and now we're at the purple. The bars look higher, but actually overall it's about 55%. When I told my daughter that, she's 12 years old, and she says, "Mom, that's a D." So in her book, it's a fail. But I am excited, I'm encouraged. And I believe that this is a bit of hope. Shows us that change is possible. What I did do, we measured this across all our sites. What we did do is I teased out 10 elements of respectful care. And what I see is that as you improve the quality of care, the elements of respectful care get better. What I don't show is that this is not constant. So if you go on the day shift, it might be 100%. I cannot assure you of the quality of care at night. So that is indeed our next challenge, is to make these changes consistent and sustainable. What is really important is that our partnership with the region and working and planning and working through them and within them allows them to complement them. And that lends sustainability and is great advocacy, because the advocacy continues even as you plan. I also believe strongly in investing in infrastructure and equipment and supplies. The local governments are stretched. They do not have money. They are providing a free delivery service, and this service is not subsidized by any donor. So it is at a tremendous cost. And so if you have the money, you really must invest if you want to see a change. One of the most powerful interventions is spending time at site. On-the-job coaching and mentoring, it builds trust, and it allows you to change the providers, so you can replace bad practice with good practices. Just give me 1 second. This is my last slide. And it allows you, one of the most important things, it allows you to build hope, and it allows you to praise, and it allows you to show them how to do the correct thing in a high volume setting. This is our challenge. And in conclusion, I'd really like to go back to the lessons that I've learned, is that that respectful care must be is part of an equality improvement program. And as anyone working in maternal care must emphasize the elements of disrespectful care, because omitting it is a great loss. I'm happy to tell you that Beatrice last year had a healthy baby boy. She's now an advocate for CCBRT, a voice calling women with fistula to come forth and for treatment, and reminding all of us of the need for respectful care. I am committed to join this voice, and I'd like to take the opportunity to call on all of us gathered here to use your position to spread the message that as part of the efforts to accelerate the reduction of maternal and newborn health, we need to include the component of respectful maternal care. Thank you.